As one of the largest GAs in the country, Arrowhead has program management down to a science. Find formulas for success at arrowheadgrp.com/science.
New trends in hiring may change the way healthcare organizations and their insurers regard medical professional liability exposures. Speaking with Insurance Journal Stephanie Jones at the Plus Medical Professional Liability Symposium in Chicago, Laurel Byerly, Senior Vice President for Third-Party Administrator, Western Litigation, explained that complications arising from increasing and diversified levels of employment among healthcare providers present new challenges for risk managers and underwriters alike.
Well, I think just in general, the more people that hospital employ, the more their risk is going to increase. If a physician is an employee of a hospital, that immediately makes the hospital vicariously liable for the acts of that employee, whether it's a nurse, a radiology tech, or a physician. They're going to be added to a lot more lawsuits simply because they are employing this person. They're going to be facing questions of whether or not this doctor was adequately credentialed, what kind of risk management programs the doctor's going through, what kind of background checks, whether or not training and everything else is up to snuff. That has gone on in the past as a normal part of the credentialing process. But now with this new employment respondeat superior relationship, it's going to become even more critical, and hospitals are going to be able to, not going to be able to get out of cases as easily maybe as they have in the past when physicians were considered independent contractors. They're going to be seen as much more responsible for the risk management and training of the physicians that they're employing. With increasing expenses on cases, one of the ways that we try to cut down on expenses is to use one attorney for all of the insured defendants in the case. But there are some cases where the defendants, even though they're all employed by the hospital, are in conflict with each other. The doctors may not feel that they're getting adequate representation. They may not feel that their side of the story is being fully heard. They may, want their attorney to go after a nurse, or the nurse may say this is the doctor's fault. We do try to manage that internally. But the question then comes up, well, let's just say we all agree that it's a case that needs to be settled. We're just not really sure who's really at fault. When those discussions come up, you're also going to have conflicts about how is this settlement going to be apportioned. We talked in the program earlier about, do doctors fully understand what they're gaining and what they're giving up when they become employees and become insureds under these various programs? Do they understand what their rights are? Have they read their employment contract? Are they asking for separate counsel? Do these programs allow for that? So I think there's a lot of questions there that still need to be worked out. And there are, differing opinions on whether or not it's best for the whole case to have one attorney and have a united defense, or, is it better to have a separate counsel and make sure that everyone's interests are protected, with the understanding that those counsel are going to, work together for the benefit of the defense. So it's still being worked out now, but it's an issue.
Hospitals and physician networks rely on mid-level providers like physician assistants and nurse practitioners to help keep the quality of healthcare high while lowering costs. Byerly says in claims prevention and management, the added exposure of those mid-level providers should be considered.
Well, this is what we refer to as the mid-level provider issue. And I want to start by saying that, first of all, most of these people are, very well trained. They have, extensive education, licensing, testing that they need to go through. And the impulse to hire them is to be able to provide more care to more patients. And the idea is you're going to put them on cases that may not require, at least initially, the intensive attention of a physician. I think what's happened is that a lot of care has been pushed down to that level. Again, it's another person to bring to the party, so to speak. So as these providers are providing more care to patients and their names are appearing in the record, plaintiff attorneys go through the record and it's like, okay, Sue Smith, PA, saw the patient. She had an opportunity, we think, to bring a particular situation to the doctor's attention. She didn't. We're naming her as a defendant. To the extent that they have separate limits under a physician policy or a hospital policy, they're now another target. It's another way to get another limit of coverage. I don't think that the mid-level provider, with the exception maybe of certified nurse midwives, has the same experience with litigation and a litigious environment that many of our physicians have. So they're not quite as sophisticated about medical malpractice as a physician would be. And they require more education from the claim staff when they are sued about what the process is about. But clearly there's a rise and an increase in claims and suits against that provider.